just about 2 to 5 students enter now. Just want a confirmation to see if you can hear me or not from group A, B, and C.
Yes, doctor, I hear you.
Which group?
Group A.
Okay. Group B. روح
جروب سي تمام دكتور.
يبقى جروب B. ضحى شعناس.
نعم دكتور تمام.
تمام. Okay, we will record this for your colleagues because I don't know if they are sleeping because of Ramadan or if they have some troubles accessing the meeting because of some issues with the university. But I'm starting to record this. Okay. It's a long period since the last lecture, and after your examination midterm, all of you did well except 2 to 3 students. I think they may fail. Most of you have 50 plus, and there are exceptional students. 2, I think, got 100 from 100. Others got 90 plus, some of them 80 plus, and 70, and so on. So I'm proud of you, all of you. And for those who failed or get less than 50, one of them, I think he or she did a fatal mistake. They answered the first question as true and false, but I don't know if they understood the question or they just didn't know the answer, so they tried to answer the other question as choose the correct answer. So they just encircled one answer. So by this, they lost most of the points. But anyhow, you have the final exam and daily attendance and activities in the clinic and maybe quizzes. So be ready for the final one. Today, we will talk about radiographical features of dental caries. How can we detect dental caries using radiograph, or how dental caries will appear on radiograph. So the outline of the lecture will be a short introduction, radiographic techniques to detect caries, radiographic detection of caries lesions like proximal surfaces, cervical burnout, root caries, occlusal surface, buccal and lingual caries, recurrent caries, and rampant caries, and the summary of the lecture. So objective will be to be familiar with different radiographical appearance of dental caries. So as an introduction, the initial caries lesion is a surface loss of mineral in the outer tooth surface. It appears clinically as a chalky white or an opaque or dark brownish spot. This is how caries appears clinically, and why it's happened. It's a demineralization of the dentine and enamel. So radiograph is useful for detecting dental caries because the caries process causes demineralization of enamel and dentine, as I said. So the lesion is seen in the radiograph as a radiolucent, like a dark zone. Why? This may be a question in the future for any quiz or final exam. So why it appears as a radiolucent? Because the demineralized area of the tooth do not absorb as many X-ray photons as an affected portion. We talked about radiation absorption, radiation deflection or scatter or anything. So any matter like dentine and enamel that contain calcium and minerals absorb X-ray. When there is caries, this area is demineralized. So this area allows less absorption of the radiation, and that's why anything with less absorption of the radiation will appear as radiolucent on the X-ray. So radiography is a valuable supplement to a thorough clinical examination of the teeth for detecting caries. Always we say, try, do a good clinical examination. If you can detect caries, that's it. You don't need further investigation like exposing patient to extra radiation to see if there is any. However, if the most meticulous clinical examination may fail to reveal demineralization beneath the surface, including occlusal surfaces, it might appear intact. When clinical access to proximal tooth surface is in contact is limited, you cannot see the beginning or the start of the caries in the interproximal surfaces. So at that time, you might ask for an X-ray. So you may detect caries using an X-ray. So as I said, good clinical examination may expose a caries. So you don't need to expose the patient for extra radiation. But sometimes on the occlusal area, patient have sign symptom of caries, pain during sweet, or there is sign symptom of starting of the pulpitis, and sometimes there is you think that there is an interproximal caries, but you cannot see it by naked eye or using mirror and probe. So taking an X-ray will reveal this better. So radiographic techniques to detect dental caries as the first line for posterior teeth mainly. The bite-wing projection is the most useful radiographic examination for detecting caries. Okay, the bite-wing. Periapical radiographs are useful primarily for detecting change in the periapical bone in the periapical area. But using of the parallel technique increase the value of this projection in detecting caries. So first of line is bite-wing. Second, periapical radiograph, parallel technique. Because for periapical we have bisecting angle technique and we have parallel technique. So using the parallel technique will reveal caries better than periapical radiograph. So traditionally size 2 adult film are used for a bite-wing examination or for a periapical one parallel technique for age of 7 to 8 years and onward. So for the small children, it's not recommended to take X-ray as we mentioned previously because of the exposures and radiation hazard. So until some age when there is caries active child, so you want to see caries and other things that are missed clinically. Radiographic detection of carious lesion we have on the proximal surface. The shape of early radiolucent lesion in the enamel is classically a triangle. Okay, this is for proximal, interproximal area, contact point of tooth. So it will be like a triangle, the base toward the outside. When the demineralization reaches the dental-enamel junction, DEJ, it spreads along the junction, frequently forming the base of the second triangle, with apex directed towards the pulp. So for interproximal area, we have double triangle, and I will tell you what I mean by this triangle. Look, if this is a tooth and this is another tooth, so this one is enamel and this one is dentine and this is the pulp. So this is the first triangle, how caries started, following the dentinal tubule path. So when X-ray come here, it shows you a clear radiolucent. Here the triangle is narrow, so it not show anything. And then the second triangle started here, so it show you another radiolucent area. So overall, the X-ray will appear as two triangles. Following image or radiographs will show you better what I mean by these triangles on interproximal surfaces. So let's go to the classification of interproximal caries. We have incipient caries, less than half of the thickness of enamel. And then we have moderate caries, greater than half of the thickness of enamel, but does not involve the dentino-enamel junction. Okay? Advanced caries involve enamel and dentino-enamel junction, and less than half of the distance to the pulp cavity. This is advanced. Severe caries, dentine penetrated more than half disease to the pulp cavity, almost near the pulp cavity. But as I always say, you cannot predict any pulp exposure using X-ray because X-ray is a 2D, but radiograph for a 3D image. This image is somehow fuzzy or blurred, but it might help you. Again, incipient, small caries, not more than half of the enamel. Moderate one, it's reached the dentino-enamel junction, not involving it. Advanced, past the dentino-enamel junction, and no more than half of the dentine. Severe, past the dentino-enamel junction with more than half of the dentine involved. See the double triangles and see on the image how it appears the proximal one. First triangle and second triangle. This is what I mean by how the caries of interproximal area diffuse or continue to grow inside the dentine and enamel. And you might, I don't know if you have got this from the conservative or operative department, any theoretical information about these, or you might get this next year. But think about the basic anatomy of the tooth, also the histology of the teeth, about the dentinal tubules and enamel rods, how they lies and their configuration. So it's not, you don't have time here to talk about these, but try to connect between these so you will understand why caries in this area will be like a triangle, that the apex or the base is toward the outside and the apex toward the inside, and the second triangle started in the dentine with the same manner, base to the outside and the apex to the inside, but there will be different in the caries on the occlusal surface. Same reason, because of the configuration of the enamel and the dentinal tubules. Again, you see the incipient one, or again, even sometimes some eyes will read this as a moderate, reach the dentino enamel, not passing it. This is the incipient one. And we have the advanced one, passing the dentino enamel junction to the dentine, but not more than half. And I will show you later some of the image that pass the half to be severe. So this is very important. Again, incipient interproximal caries of the anterior teeth, an advanced one because the enamel here is past the dentino enamel junction and not going further more than half of the dentine. Again, this is advanced one. If you concentrate, the first triangle is here, and and the second, the base of the second is started to show as a radiolucent. Sometimes it will be difficult for you at the beginning to detect these caries exactly because it depends on experience. Okay? Can you see caries here? Yes, of course. There is incipient to moderate, incipient, 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 and this is advanced one. See the first triangle here and the second one here. So this is how caries appears on a radiograph. There is a term called cervical burnout. Okay, so cervical burnout is a diffuse radiolucent area with ill-defined borders, may be apparent radiographically on the mesial or distal aspect of the teeth in the cervical region between the edge of enamel cup and the crest of alveolar ridge. This is very important because sometimes you might be confused between cervical burnout and root caries. So why cervical burnouts happen? As we said, because of the normal configuration of teeth in some area in the cervical area. So there will be less absorption of the X-ray in this area than the other area. So at the end, it will appear as a radiolucency, but it is between the cup of the enamel cup here, between the dentino enamel junction or the cervical enamel junction and the crest of the alveolar bone. So you will see it at a radiolucency. So this is caused by the normal configuration of the teeth, which result in decreased X-ray absorption in the mesial and distal aspect of the teeth. And that's why it's appear as a radiolucent. It's a normal phenomena. You might get a question on the exam. Is a cervical burnout caries? No, it's not caries. It's a normal phenomenon. Why it will happen? Because of the normal configuration of the teeth that result in decreased X-ray absorption. Look here, you will see that there is a radiolucency between the cup of the enamel and the crest of alveolus. There is a radiolucency band. All of this is cervical burnout. It's not a caries. Okay? Look here. This one is a severe caries, real caries. This one is advanced to severe caries, but this one is cervical burnout, as I said, which is a normal phenomena rather than a true caries. Root caries. So going back to the previous slide, look to the cervical burnout. There's a radiolucency between the cup of the enamel and the alveolar bone. And look to this image. It's a root caries. Why? It's like a cupped out or crater-shaped radiolucent below cemento enamel junction. And look the superior border of the alveolar bone. Mostly it happened due to food impaction or bad oral hygiene or some other diseases that decrease saliva. So mostly root caries can happen, or if there is any impacted tooth, so it will be difficult to make it clean. So this was about root caries. Any question? Let me see how many people are in for the moment. ميديا يوسف يحيى زكريا شاناز ضحى ما كان داخله. فاطمة شهد عامر يعني شهد خميس شهد عباس. اوكي عندنا ما شاء الله هذا ياهو جروب اي لوسي حنين جيار احمد انس ورد احمد زبيده.
دكتور بس هاي المنطقة البيضاء هاي حشوة قديمة مو؟
يا بيضة يا بطيء وين رحنا؟
طلع موجودة هذا المكان.
العصورة اي هاي حشوات امالجم قديمة. عادة الحشوات تبين از راديو اوبك، انه مثل ما قلنا انه كمية الامتصاص الراديشن تكون اكثر فتظهر على راديو اوباست. هاي راح نحكيكم عليها بعدين بالمحاضرات القادمة. Any other question before proceeding with the rest of the slides for today? ماكو. Okay, let's continue. Occlusal surface caries. This is a histological appearance. And again, in the interproximal area, as you said, the configuration of the dentinal tubule and enamel rod is different from the occlusal surface. That's why in the occlusal surface, caries will appear as a triangle, but this time the base of the triangle will be at the dentino-enamel junction, and the apex will be to the outside. But for the interproximal, caries is vice versa, or it's the other way around. The classic radiographic appearance of occlusal caries extending into the dentine is a broad-based radiolucent zone, often beneath a fissure, with little or no apparent change in the enamel. Clinically, you cannot maybe see. Always we say the occlusal caries is like an iceberg. When you see little of it on the ocean or on the sea, but most of the parts are beneath it. سو مثل جبل جليدي مثل هاي صارت بالتايتانيك. القطعة ظاهرة تكون كلش قليلة بس الجو ما خفي يكون أعظم. فالأوكلوزال caries is exactly the same. You might not see, you're not detected on the radiograph, or maybe even a pinpoint caries, but the broad base is toward the dentino-enamel junction. So any small caries on the occlusal, that means there is a diffuse or advanced caries beneath it. So it will appear like a diffuse base between. One thing is very important for detecting occlusal caries is having a good between X-ray. If you have wrong X-ray or any fault, technical error in the X-ray, you may not get it because it needs to X-ray to be passed through the demineralized area. But if there is an angulation error, like vertical and horizontal angulation error, at that time you will not get that nice image, and the caries will be hidden or obscured. So the good radiographic technique will reveal caries. Here we have what we call secondary caries. I will talk about that soon. We have buccal and lingual surfaces. Buccal and lingual caries lesions often occur in enamel pits and fissures of the teeth. When small, these lesions are usually round. As they enlarge, they become elliptical or semilunar. Clinical evaluation is the definitive method. Because why? You cannot detect these on the radiograph, or if they are small, because the caries will be overlapped on the pulp chamber. Imagine buccal and lingual caries on the buccal and lingual aspect of the tooth. When you get the radiograph, these will be overlapped on the pulp chamber, so you will miss these by radiograph. So the better diagnosis for buccal and lingual surfaces is clinical evaluation. You can see it directly by eye. Using mirror and probe, you will detect buccal and lingual surface caries. But when enlarged, or sometime here we have a buccal caries, look, it's a radiolucent superior to pulp chamber, so it's appear here clearly, but sometimes not getting a nice radiograph or even have a larger size. It might be overlapped on the radiolucency of the pulp, so it will not appear radiographically. Just so let me see. يا ماكو هواية طمطم بالجروب، ما أعرف شنو السالفة. أكو ناس يريدون يدخلون. عمر فاروق أوتسايد الكتاب. هذا أوتسايد الكتاب اليونيفرسيتي. أوكي تفضل.
طالب ويانا بس كان اكو مشكله بالحسابات ما جاي تدخل الحسابات.
تمام، شرحوا لي عنها بس ما فهمت شنو السالفة، فحتى قررنا ننطي محاضرة ما ننطي، بس قلنا ما طول راح نسوي ريكورد، فالأحسن ننطيها لأن عندكم إنه أكثر من 10 15 ما أعرف قد المحاضرة باقية، فلازم نكملها وإلا راح تعاتبوني بالنهاية تقولون إنه المرحلة الثالثة ما أخذنا المحاضرات كافية على مود هاي المرحلة الرابعة ومرحلة الخامسة من نتكلم أشياء related to X-ray. فهي هم بالأيام العادية ما كانوا كلهم يدخلون، بس يا حسافة يعني إنه كانوا يعني عدد مو قليل يدخل، يعني كلش زين كنتوا والمناقشات كانت طيبة. بس المحاضرة مال كيريز إنه أشوفها سمبل وطيبة، يعني حتى الواحد إذا بعدين يرجع على الريكورد ويرجع ياخذ الPDF ما اتصور راح يكون عنده مشكله بالفهم، مو مثل الفيزيكس وبقيه الاشياء اللي لازم انه واحد يكون حاضر. هذا مو تشجيع عن انه لا تحضرون، بس اليوم اذا تشوفون سويت جنب المحاضره كان لازم احكي على غير محاضرات، بس انه سوري اخذت الكيريس خاطر انه الجماعه اللي ما داخلين او سبب رمضان انه اكو ناس نايمه تقعد بالليل للصبح والصبح تنام للظهر، فهم خاطر لا يفوت عليكم أي معلومة مهمة تحتاج شرح أو تحتاج كونتاكت أو تحتاج مناقشة على المنصة. Okay? So, this is about buccal caries. Now we have recurrent caries or secondary caries. What do we mean by this? Secondary caries or recurrent caries occurs adjacent to pre-existing restoration. When there is any cavity preparation, it's not prepared well, there is still remnant of the caries not removed by preparation. So after that, caries will start again at some point. It's called secondary caries or recurrent caries. Or the filling of restoration is not fitted well, so there is leakage of the saliva and bacteria at this area. So there will be something called recurrent or secondary caries. So we have primary caries, the start, the caries, the original caries called primary caries, and any remnant or existence of the caries after doing a restoration called recurrent or secondary caries. So caries occur because inadequately cavity preparation, defective margin, or incomplete removal of caries. So بقايا الكيريز أو الكيريز المعاد، تمام؟ Or radiograph, recurrent caries appears as a radiolucent area just beneath a restoration. Whenever you see a restoration, there is a radiolucent area beneath it. So this will be managed or will be named as a recurrent or secondary caries. It mostly occurs beneath interproximal margin of restoration. So here, all these whites radio opacities are amalgam. It might be this is composite restoration. See the opacity, the radio opacity of the amalgam. It's metal, or the atomic number for the amalgam is higher than composite. So the composite is most like or resemble the or slightly more opaque, more white than enamel, but amalgam it's more whitish one. Anyhow, this radiolucency and this radiolucency beneath the restoration, this one and this one, all are recurrent or secondary caries. Okay? Any radiolucency beneath the pre-existing restoration is called secondary or recurrent caries. So maybe this is not fitted well, or there is food impaction here. So the cleansing area is not good, not using flossing, not using good brushing technique. Here is the same, but here it's maybe the amalgam, the margin is not fitted well. So there is leakage of the saliva and bacteria, or the caries is not removed properly in this area. So there is still some caries and bacteria here, even though there is a restoration. So the process is started again and continued. So there will be again a caries beneath restoration. Okay. Rampant caries, you might hear about this, or you will hear about this next year in the pediodontology or pediatric dentistry. Rampant caries, rampant for its name, is advanced and severe caries that affect numerous teeth. It's typically seen in children with poor dietary habits or in adults with decreased salivary flow. شوفوا الأطفال اللي أهاليهم إنه احتمال كثير من عندكم هم يعني حتى الأدلت 24 ساعة نستلة 24 ساعة sugar, chocolate, موطة, anything without brushing teeth or even poor dietary habit or oral hygiene is not good. فتشوف الأسنونة خاصة upper anterior. Whenever you see anterior teeth, all anterior teeth are carious lesion, upper and lower, mostly upper, and that means the oral hygiene is not good or there is underlying disease need to be solved, because this is a clue of rampant caries, like numerous teeth will be affected. مثلا نشوف a child with 20 teeth and all teeth have caries lesion, or an adult with multiple or numerous teeth, maybe they have some problem with the salivary flow, that saliva washing teeth and have increasing immunity and fighting with the bacteria in oral cavity. But if there is a decreased salivary flow, one of the problems that cause rampant caries, and there are many causes for decreasing salivary flow. You will get this maybe next year or the year after in the oral medicine. So for you radiographically, if you see numerous teeth with caries, this is just clinically called rampant caries, but you have to deal with every tooth separately. But most important is giving information and patient motivation. مثل الاهالي يقولون خطيه خلي ياكل، احنا بزماننا كان حصار وما اكلنا وما شبعنا، الاطفال خلي ياكلون شيبس نستله، فاي وقت اي ساعه ما عندنا مشكله بالليل ياكلون وينامون. فهنا تشوف انه عباله انه بده يخلي انه الشيء اللي صار بيه بايام زمان انه ما ينعاد على طفله، انه ما يكون عينه على شيء وما ياخذه، هم غلط. هاي صارت هنا بالعراق مو مشكله، ممكن بالسويد انه حتى بريطانيا كانوا يجون اهالي يابا انه مو علموكم بالمدرسه والاولاد حتى بالحضانه، من اول ما الطفل يجي قبل لا يروح الحضانه يعلموهم انه شلون يدارون اسنان اطفالهم. يجي لك العراقي يقول لك الضيم اللي شفناه احنا بوقتنا خل الاطفال يشبعون وياكلون. يابا مو قضيه انه اذا مو انت هم ضد الطفل نفس الشيء، يعني هم راح تشوف ضيم انه الاسنان راح تتخربط، راح يصير عنده كيريس، راح يصير عنده الم. تعال النوم انه اشلع هذا السن وحشي هذا السن. فمرات انه مفهومنا لانه الدلع، مفهومنا انه الطفل خلي تكون عينه شبعانه، او انه الشيء اللي صار بينا ايام زمان نحاول انه ما ينعاد على اطفالنا. بس احنا دائما نقول الشيء المرات نقول انه رب ضارة نافعه، انه الحصار فادنا ناحيه الكيريس، لانه ما كان اكو نستله، ما كان اكو شكر. اسالوا اللي اكبر من عندكم، ابائكم امهاتكم، انه الحصار ادى الى نقص فظيع بالشكر والحلويات، والناس كانت فقراء. فالحمد لله انه اسناننا كانت احسن من الدول المتقدمه. بس ما عندنا ابحاث راقيه هيك تدور انه ليش بايام الحصاد كانت اسناننا هيك. هاي ترجع جماعه الكوميونتي والبريفنشن. ما تعبكم، دائما احاول مرات اربط بين المحاضره وبين الحالات اللي شايفينها والاكسبيرينس that we have in our life. So this is about rampant caries. Lastly is errors in technique may result in non-diagnostic failure. قلت لكم بالبدايه انه اذا ما تاخذ اكس راي مضبوطه فاحتمال راح يكون عندك كيريس في مكان فانت ما راح تشوفه. مثلا بالبايت wing, the enemy of the bite wing is overlap, when you will not get like a nice horizontal angulation. So it's always recommended that the horizontal x-rays goes between the contact area, so you will get a separated contact like this area, but not even this one, like this one. There is no overlapping. You can see the enamel of both teeth, but see this, there is overlapping of the proximal surfaces of all teeth, and if there is any caries in this area, it will be hidden. You will not see it. So patient will come and go and back and saying, I have pain during eating sweet or sometimes drinking water, and you might suspect there is a caries, but doing a clinical examination with mirror and probe, you will not see it. Taking a radiograph, but you will do an error in the technique, you will not see it. And you will tell the patient, روح ما عندك أي مشكلة, نظف أسنانك, there is no caries. And patient going to another dental clinic, they will get a perfect radiograph and they will see the caries. At that time المريض راح يقول تعالى راح يم فلان على اساس فلان يفتهم وقرايبنا واصحابي وما اعرف شنو اشو ما شخص لي السن وانت تقول تقول لي هنا عندك تسوس. فشوف انه any error in the technique, this technique radiograph, we always say all of these are helping in to get the diagnosis, and the diagnosis is the first layer or the first line of starting a treatment plan. If you can't get to the proper diagnosis, of course you will not start a good treatment and treatment plan. So the other one is condition resembling caries, as we said, like cervical burnout. So cervical burnout appears as a collar or wedge-shaped radiolucency on the mesial and distal root surface near the cement to enamel junction of the teeth, as we talked about this. So this is normal phenomena. So it may be confused with root caries. Always look at the alveolar bone level. So most of the dentists sometimes say, oh, there's a caries here, and they starting drilling and doing restoration for the area where it is clean and clear and there is no any pathology in this area. So again, you may hurt your patient by misdiagnosing. So always we say it's better to know the normal phenomena or normal radiological finding on the X-ray and then start to see the pathological one to know how to differentiate between the normal and pathological one. Because if you don't know the normal one, you might be confused at the end to say this is a pathology and you're starting to deal with it as a pathology. Later we will start or you will start to do a drilling or taking out the tooth without any objective, and at the end it will be normal, but you get like a wrong diagnosis on that. So be aware of this. Again, we said, as I told you in the beginning, it will be difficult for you to find caries. You will just detect a clear caries that's shouting. الكاريس انه التسوس راح يقول لك هاي I am here، راح يصيح بالاشعه راح تشوفها. But with the time and experience, so of course the caries detection will increase as much as you see patients and cases. So your experience will be increased with the time. So even you'll detect a small incipient caries interproximally. And something is very important, but it's not applied here. According to all guidelines, international guidelines, like simple incipient caries and moderate one that's not reached the dentino enamel junction, is all two of these not needed any restoration, because these are enamel caries with doing a proper brushing and flossing and taking fluoride, supplementary fluoride, so the caries will be ceased, will stop. So most of these, it will be arrested caries. It will be caries, but it will be stopped, not going further. And in the developed countries, they try to see these patients regularly every year and taking a bite-wing radiograph and compare with the previous radiograph to see if the situation is worsened or it's still arrested caries. So it's very, very important. But here, unfortunately, again, whenever they see a simple pinpoint caries interproximally, they starting drilling and do a big box and starting to fill it with the amalgam or composite. And honestly, it was not needed because, as I said, all developed countries, Europe and USA, Canada, Australia, and some other countries, except us as usual. So they are dealing with the national guidelines and recommendations for preventive dentistry and conservative and other specialties relating to the caries, and they always say doing flossing, brushing, taking fluoride supplement, and this caries will be ceased. It happened to me again. I talking about my experience. لكن ماخذ فايتوينج 2006 شفت انه اكو كيريز، يلا قبل لا اسافر للسويد نحشيها ما نحشيها. فورtunately ما صار عندنا مجال وما حشيتها. بالسويد اخذ المطلوب انه نورمال تشيكينج قبل لا اعاد الشهاده وارجع اشتغل. سبحان الله بنفس المركز اللي بعدين اشتغلت بنفس المستشفى. فاخذنا اكس راي 2007 انه الدنتس قال لي انه الكيريز هذا ما يحتاج انه حشيه، انه جاست انه نورمال ميجر. ما كنا متعلمين او ما كنا نعرف بهاي الجايد لاينز. فقلت شلون كيريز وراح تبقي؟ قال نبقيه وراح نسوي فولو اب، وكل سنه من تجي راح نفحص. امرت له، وانا بهالاثناء سويت عادلت شهادتي وقريت وش اسمه مالتهم الجايد لاينز. قلت يعني هم كنت مقتنع بها، يعني معقوله كيريز موجود انتر بروكسيمالي والطبيب ده يقول لي والدراسات تقول انه عوفه ولا تشيله ولا تسوي فيلنج، يعني غير شو اسمه. قلت احتمال دول قضيه ضني وترتيبات انه ما يريدون يصرفون واحنا اجانب ما اعرف شنو، يعني سويت قصه معينه انه دا اقنع نفسي انه هذا الشيء انه غلط. السنه اللي وراء عدلت شهاده وبديت اشتغل بنفس المستشفى ودا اتابع حالتي وحالات المرضى ونفس الشيء دا اتابع. شو سنه ورا سنه الكيريز اللي انا ب 2007 2006 7 ماخذين لي اكس راي لحد هسه اللي هو صار ارستد كيريز انتر بروكسيمالي، يعني ورا تقريبا 14 15 سنه هو الكيريز متوقف. والحالات اللي انا تابعتها مرضى اللي يجون سنويا نفس الشيء تشوف الكيريز متوقف. يعني اذا حتى واحد مراد يشك بالعلم يجي يطبقه ويشوف بعينه انه راح يصدق انه هذا الشيء انه واقع. فانه I advise you not to touch any incipient to moderate interproximal caries. Just motivate the patient about the measures to do before starting drilling unwanted drills area. At the end, summary of the lecture. So we say dental image allows the dental professional to identify caries lesions that are not visible clinically. Caries appears as a radiolucent on the dental image. Dental caries may involve any surface of tooth, crown, and root. Finally, if there is any questions, as we say, there are no stupid questions or stupid answers. So if you have questions, I am happy to answer. You have about now 10 minutes to the end of the lecture. Let's see كم واحد بقى بالجروب، كم واحد نام. تسعة هنا including me، 14 هنا. بس يحيى زكريا جروب سيلو. أي يحيى أنت؟
جروب سي دكتور.
خطية لوحدك أنت، وين أصدقائك؟ نسرين هسه تطب، يلا تفضلي نسرين، ما عندي مشكلة. خطية راحت. تمام. Any question؟
دكتور مرات التايب اوف ذا فيلم هم يأثر على اذا كان كيريز يبين او لا؟
اي تايب اوف ذا فيلم، التكنيك، يعني انه الكونفنشنال اذا التكنيك مو زين، انه الاكسبوجر مو تمام، الديفلوبينج مو تمام، اكو ايرورز، اكو اشياء راح تاثر بالشو اسمه الديجيتال 1. نفس الشيء انه تايب اوف ذا فيلم، تايب اوف ذا سنسور، تايب اوف ذا، اذا سنسور بي ايرور، اذا السوفت وير مو تمام، اذا الكونتراست والريزوليوشن واحد ما يعرف يسوي ادجست بالديجيتال 1 هم راح تاثر اوف كورس. هم اكو دقوا على الباب. يوسف ارشد تفضل. Any question؟
دكتور اذا عندنا بوكر فيلينج مثلا بالتوث، فناب الاشعه راح اذا خاصه بي اوفر يعني راح يبين انه هو قريب من الروت يعني.
مو انت لازم
شلون راح نميزه؟
انت كلينيكلي راح تميزه. يعني عندك انه بوكر فيلينج، بوكر ريستوريشن، اوف كورس بالاكس راي راح يبين عندك راديو اوبيك مو راديو لوسين. الريستوريشن يطلع راديو اوبيك، راح يطلع عندك راديو اوباسيتي على الباوت شامبر، مو بس انت ما مشيد على الاكس راي دايركتلي without having any clinical examination. فاصلا ما ننصح انه حتى بوكال او lingual كيري او restoration. No, when you see it by naked eye, it's not needed any X-ray to confirm that, because X-ray will not help you. تمام.
مو هو دكتور ذيك المره بيشنت يعني اجى للعيادات فعنده بوكر فيلينج ومسوي يعني حشوه صار له تقريبا شهرين ثلاثه ويشتكي من الم يعني. فبوقت الطالب ما عرف يعني هل هو قريب من الجذر لو بسبب البوكال بيت اللي مسوي له فيلينج يعني.
مو بوكال بيت، البوكال بيت حتى الاكس راي ما راح تفيدك. انت الاكس راي قبل تقرر يا تكنيك تاخذ لازم تفكر انه هذا الاكس راي ايش راح يفيدني؟ انا عندي بوكال ريستوريشن، فاذا اخذ اكس راي ايش راح اشوف بالاكس راي؟ هو راح يطلع 2 دي ايمج، صح ولا لا؟ الاكس راي كونفنشن هو 2 دي، راح يطلع ريستوريشن اوفرلاب اون ذا بولب شامبر، ما راح يبين لي انه اكو سكندري كيريز او لا. فدائما ينصحون اذا اكو suspected pain due to any buccal or lingual restoration، اذا ال other area adjacent tooth and the opposing tooth and there is no interproximal caries or occlusal caries, if you suspect that the pain is from the buccal one, so it's better to remove the restoration and see if there is any secondary caries or recurrent caries beneath the restoration, make it clean and put a temporary filling TF in the area and wait for minimum 4 weeks to see the response of the tooth. So the buccal restoration may not need any radiograph at all. Okay? أهلا وسهلا. اليوم سقيتها كلها الاكسبلانيشن بالعربي، ما اعرف اذا اكو انه طلاب اكراد ما افتهموا علي تريدون ارجع اشرح لكم بالكردي. اذا اكو مسيحي مجد مهيل سالم توما، اذا تريد احكي لك بالمسيحي او اذا كلكم فهمتوا، لان موستلي كانت 90% 95% انجلش، بس مراد واحد انه القضايا التفسيريه يريد انه يوصلها باللغه الدارجه خاطر تفهموها احسن. Any comment؟ تمام، استودعكم الى الاسبوع القادم. انا قلت شو اسمه طارق موجود ويانا مو؟